I believe it is. I think it is too also.
Deb is third.
Okay. Do we have a quorum of two or we need three?
Two.
All right, this should be a very short meeting. That's called to order. Do we need a roll call?
I don't have a roll call sheet, but
Okay, well,
everyone's attendance.
within the agenda, it's very short. Is anybody, would somebody like to make a motion, or would you like to have?
I do second.
Okay, then, there's no objection. We'll move right through this short agenda. Did anyone else look at the minutes?
I did. Move to approve the minutes.
I'll second.
Okay. And there wouldn't be any objections, so we'll speak to those three. Training, board training committee discussion, so. I think the only thing we might discuss, I don't know, you may have other things you want to discuss. We still have a couple of people who didn't turn
I would be one of them.
their forms in. So we guess we could discuss what we're gonna do to those people.
Hit my other knee or? I will have it in before the first of the year.
Is there anything else to discuss about board training?
Alex, I mean,
Yes, please.
I would like to know the feedback for the format that we followed. If the board has any kind of, you know, something that they wanted to share about whether or not they liked the self-paced, whether they liked the modules or whether they would prefer an in-person like we've done in the past or something different.
We were just talking about that in the fall.
Yes.
No, I love that format, and I wanted to say something at the main meeting, but our board meetings go 3 hours, so I tend not to talk. But so I wanted to give a great shout out. I love that you made it so idiot proof for us. There are so many mandated rules to come down as being a position. We have to do opioid CME, we have to do CME for this, and yet they make it painful to do it. We have to pay for courses or do it. You made it so easy. We could do it on our own pace. And I think it's just wonderful.
That's why.
I think, and if you polled other people, they strongly would expect, because that doesn't force everybody to drive down here, get in the same room, you know, coordinating can be very difficult. I think everybody on the board is a serious person. They're all pretty responsible folks. I think we can all admit. And so when they say they did it, you know, I suspect that they did it. So if you could just keep us on task with a sort of a series of courses that sort of fulfill the requirements, then I think that would make me happy. Thank you.
I'm in agreement. I would like us to consider maybe once or twice having an opportunity. Some of the topics could use some Q&A, some explanation. So if we find a topic in this process that requires more depth, I'd like us to have the opportunity available for either a Zoom or an in-person conversation about the questions we have about what we learned. So that's my only comment about it.
So the chair, that was my concern on some of them. They were just, and I think Hal and I talked a little bit, it seemed like they were just a taste. And that was my question with Dr. Jones is, was his comment, was it enough? Because it was just a little, just of an overview. So should we look for maybe some that on some of the topics that may be a little bit more substantial? You know, I'm not saying an hour long, but maybe.
If I could take a chance too. I very much like that it was a very manageable time commitment, and it was time well spent. I don't know that we can really count on the Office of Inspector General and those attorneys to be people who put on the most entertaining presentation. I thought sometimes, as I was watching, I thought, well, this could be presented better. Okay, so that's kind of a useless comment, because who would present it better? There's a lot of material on the internet there's nobody to judge whether it's credible. There's a lot of law offices that have seminars on these that are maybe presented better, but I don't know if they're as credible. So, yeah, I don't know. But as I watched some of those, I felt like I went away at the end of it, still not knowing what I wanted to know. But I think that's a criticism of the Office of Inspector General's content.
If I may, through the chair. And I struggled to pull out the question from Dr. Jones's comment, and I think to also Deb's point, this is where we rely on the board to tell us, what is it that you did have questions about? What is it that you want more information on? And then we can synthesize that and give whatever it is that's appropriate. So,
You know, the Stark laws, that could be, you might think, well, that's just all obvious, but as I've gone through this material, not just through what we just watched, but elsewhere too, and they say, well, we have the safe harbor for this and safe harbor for that. The safe harbors, I didn't think what exactly the safe harbors are, more details about that. Would have left, if I understood that, it would left me more satisfied. Of course, that would require a lot more time. Where would you get that specific information? I don't know. This is a topic, the Stark law is something we need to know about. And then the safe harbors, an important component of it. So those seem to be just glossed over in most of the material I've looked at.
you're looking at me, so I'm getting the answer.
No, I mean, it's not a criticism of you. It's just kind of a comment about my journey to try to figure out what is the Stark laws.
Yeah, so if I may, the important thing to understand about some of these laws that are specific to compliance is that there are some lawyers that spend their whole career on just safe harbors. I mean, not even Stark, but just safe harbors. I mean, so there is a really, really big pit that you could end up going down if you wanted to understand all of those. And as a board member, this is probably more of a conversation about what's the appropriate level of understanding to make sure that we have the institutional knowledge to understand those and that we're following them. I think is probably a bigger governance kind of question.
If I may, I think that from a medical staff perspective, we have to fulfill certain obligations. And I remember some of my colleagues saying, what's the law when I was chief of staff? Well, we should do one iota above. You know, they're very minimalist. Our board is not quite that way. I don't think any of us want to learn about constitutional law or, you know, go into these deep pits and learn as much as possible. But we want to do what we need to do. And then to Deb's point, I think it is great if we pick a subject, perhaps for a half-an-hour conference beforehand, a hot topic, if you will. So for instance, the Stark law or fair market value, you know, the sort of one thing. But we are kind of relying on you, Nathan, because you know more about what would be expected for an institution of our size. You have so much, it's your area of expertise. You know, there's a statistician, you know, there's a government worker, an NGO, and I'm a physician. So we do rely on you. I do.
Is there any other comments from that?
I could add a comment there, Chairman, that part of the board's role is that, for example, let's just use a transaction, is to say, of a transaction of this nature, what laws are applicable, and how will we satisfy those to make sure that this transaction is done in compliance with state, federal, whatever law those are. So I think part of the education is to give you the understanding that those types of questions need to be asked whenever you have certain types of transactions, you know, purchase of a physician clinic, physician salaries, other, you know, major transactions, just like, you know, how does this fit in and affect our Medicare reimbursement? Those are basic questions that I think the board should be holding leadership accountable to answer. You know, we, for example, the answer might be, we had our healthcare specialist review this transaction. It's, and the laws that we have to comply with this transaction are X, Y, and Z, and here's how we comply with them. So that you feel comfortable that we are complying with the laws as is. If you want to take a specific transaction and delve into it, you know, further, like, why can't we use the safe harbor? Then I think it gets down to making legal come in and say, this is really the nuances of the law. But I think just being able to ask us the basic questions, what laws does this transaction impact, and are we following? Or two basic questions. Yes.
I'm sorry, I interrupted.
No, I'm done.
So my vision of our responsibility is that we have to understand what areas of compliance that apply specifically to us, but not at the micro level, at the macro level. And we would rely on our subject matter experts in the room and in legal to building on what Ian says, to keep us between the fence posts, to help us understand what our risks are, our specific risks for the operation of Bartlett Regional Hospital and its affiliated organizations or departments or what have you, and then ask the questions as Ian said, if we have a specific transaction or circumstance that we want to take a deep dive into. I'll just give you an example. When I was at the university, universities, higher ed and healthcare have a ridiculous number of federal guidelines that they need to follow. We did a deep dive to figure out which of those specifically applied to us, and from there we used our subject matter experts, either in our legal counsel or within our departments, to, as I said, to keep us between the fence posts. But you know, as the risk management officer, I knew a lot, but I could not I couldn't understand every single item. I'll give you an example. When we were subject to HIPAA, and when high tech came in, high tech just went. I mean, I understood what it was supposed to cover. It's something that I would like to see on under new business, the proposed 2024. It's something that I'd like to see a high overview, so folks our board understands what that means for us. But high tech was something that I just, I turned over to the chief information officer to take the deep dive, tell me what applies to specifically to a university with a student clinic. And that was all I wanted to learn. That makes sense.
Have we exhausted this topic? Nathan, do you feel like you've gotten adequate feedback?
Yes, thank you.
Any other comments from staff? Staff members? Okay. The compliance work plan schedule. So when I started on this committee, I didn't really know what work products we were supposed to produce, and I really didn't have any idea of a schedule. So I've been talking about offering something as a proposed schedule for the committee for next year. Other committee members had a look at this, thought about it. Thought we should talk about this a little bit. what to expect in terms of when things are gonna get done. That's my question to the committee, and what the specific work product. So the question is, when should we expect certain things, and what specific work products should we expect the committee to produce next year?
I mean,
Please.
it's my third meeting, so my experience is, that of a newborn, mostly. And so that looks like a great outline, but I'd be interested in what historically have we done? I mean, I know you haven't been on the committee more than what, a couple, 3 years, so.
No, it was 1 year.
Oh, 1 year. So then I would ask, if I was asked, Nathan, you've been around for 3 years, sorry to keep picking on you, but, or 4 years or 5 years, I don't know, but more years than us. What is a typical, what have you done in the past?
If I may, through the chair, there are certain expectations that the government has for the board to exercise and demonstrate oversight of the compliance program. And some of these include an annual review of certain documents, and I think this is accurately reflects and separates out, because I mean, you could just have one meeting a year and just have too much to review. But separating it out between the quarterly meetings, I think makes a lot of sense. But yeah, policies, the compliance policy should be reviewed. The work plan and the risk assessment should always be reviewed by the board. And then education for the following year and in the last quarter, moving forward for the next. It's also a good idea, so.
So through the chair, what I did is I went back to all the board documents back through 2018. And I reviewed every single board compliance meeting through 2018 and went through your historic documents and had the pleasure of reading all of them. And I took what has been done historically. The one thing that was added is there was never a compliance plan per se reviewed. So that is the one thing that I added. Two things is having a structured program evaluation and that leading into a compliance plan review, because that is something that needs to be done every year and then taken to the full board for approval each year. So that's the one thing that I think will after this year will probably change a little bit of the structure is our hospital risk assessment. We may look at changing that to a different quarter because that kind of leads into the plan review. So we might make changes next year to that, but I think this is a good outline for this coming year.
For those of us who have been on the bidding, so we didn't even really look at the risk assessment this year. That was one of the real responsibilities of this committee, and
And through the chair, I believe it's been 2 years since the risk assessment was done. If I recall on looking at the documents.
I think I've been on this committee for 5 years now. And it's been a while. 2 years sounds about right.
Yes.
2021.
Yeah.
20 or 21, something like that. So my question is, and it's been long enough that I don't remember, where does that information, who generates the risk assessment for us to review?
I will defer to Nathan. He's been working on that.
So through the chair, the risk assessment comes from staff. And there's different ways that this information comes through. So this year I sent out probably 30 different, very specific and targeted questionnaires to staff that they are asked to give feedback. There's also interviews and then also observations. So those would be the three things typically, generally, that would inform the risk assessment. Once the risk assessment has been collated, at least through my lens, then it gets turned over to the hospital compliance committee to review. And at this point, they can look at and inform and give feedback on where they're ranked. And we used the sliding scale stoplight methodology of red, yellow, green, and where each of the topics is ranked out. So they could give feedback that, you know, this needs to be higher or this needs to be lower, or that we need to add more items to that risk assessment. So we're almost to the completion. In fact, this last week, we had a hospital compliance committee meeting where we reviewed that, and it's in its final review stages. And we have close to 30 different areas that we've ranked out, looked at, and reviewed, and we'll have finalized for the first quarter of the next compliance and audit committee meeting.
Mr. Chair, I have another question. So in general, there for any hospital, ours would be a little bit different than others, say Providence, but there in general, there are areas of risk that are should always take priority, that we need to take a look at, not just the groundswell from our staff and our physicians. So how does that happen? I mean, Ian, I don't know if you can comment on how a risk assessment has been done in your career in the past.
It's really different because in larger organizations, you typically have a fairly large risk compliance staff as well as internal audit. And what they do is they look at the planning that the OIG goes through. They usually put out a document. I don't know how often, but it's relatively accessible. They update it probably annually.
Yes, we did.
Biannually, and then off of that, you start your planning process. So that's one. The other is gathering it from others. The internal audit would come through and take a look at what they thought were the largest risk areas in hospitals, which tend to be around billing and around any business relationships, especially with physicians. And then if there was significant issues like emergent acquisition, that would also then trigger it. So that internal audit group along with compliance would come together with the various different issues. They'd also look at the audit and see what issues came out of the audit of the management letter and incorporate those. So it was a very large gathering of information. And then you have to use your professional judgment. You know, AP could be a risk, but it's not going to be a big risk. Accounts payable, it's not going to be that big of a risk. But one of the things that used to happen is they meet with me and I tell them, you know, one of our biggest risks to clinical operations is our IT systems. If those go down, it's not protected. So it is a somewhat of responding to what the government plans to look at, gathering information that you're getting from the field, other people using professional judgment, and the president, the CFO, and usually COO sitting down and saying, here's where we think we have problems in our operations. So that's the way it was done in my last two jobs, one in Indianapolis, the other in Seattle. Prior to that, it wasn't as big of a deal.
So I guess my next question is, what you described is much like an enterprise risk assessment.
Right.
Is our risk assessment specific to compliance, or as you mentioned,
Broader, right?
or is it broader to talk about? There is an element of governmental oversight for information gathering and storage and distribution, but not always. The broader risk that you brought up was if the system goes down, where's our backup? All of those things.
There are risks
That's
that
something
that are specifically legal in nature, and we have to comply with that. There are other risks that are more business in nature, and the process that I described wanted both of those done. So we had a risk for old infrastructure for IT, and we go down. And then all of a sudden, because it went down, you have to have paper processes, things would get lost in that way. So those were some of the things that we wanted to make sure that we were looking broader at all the risks, not just, risk related to clearly just compliance with others. Sometimes there would be clinical risk related to quality mixed into that. So, undercoding, overcoding is a legal problem. Undercoding is a business problem, is the way to think about it. So we wanted to be right in the middle of those two. We don't want to be too aggressive. We don't want to be unaggressive. We want to be right where we should be. So we looked at that broader than maybe just the compliance. But again, you have to start someplace, and following the law, I think, is the basic foundational area.
If I may, Mr. Chair, I don't want us to reinvent the wheel this next year, but I would like us to consider broadening our risks, because we have had issues that that started out as reputational and or other or business related that have spilled over into the compliance, and I'd like us to consider taking a look at how we can bring in the areas, the non-compliance areas that are the highest risk of affecting
Sure.
our
An example that we're dealing with, it's a business risk, is whenever you start a new service, right, and you have to get your surveys done, you're taking on a business risk of you can't bill until that survey is done and complete and, fully functional. So the risk in that case would be, we have to fund operations for the time being, and if we don't get that survey, then it's going to be a hard time billing for those initial cases that we had. So that's a business risk. It's not necessarily a legal risk. But, we were taking those risks all the time. And I think it's important for board members to understand that the way Medicare works is you don't get paid until you've gone through the survey. They outsource those surveys usually to the state or to other national bodies, and you're at the mercy of when they can get to it. So that's just a normal business risk that we have. And there's others like, are we following, let's say down in the state of Washington, they have very aggressive self-pay procedures that you need to follow. When that was outsourced to a group, they weren't following the state law. So we had a risk there, and we paid for that risk. Right. So that was a legal risk that was embedded in our operational processes. So I would support that.
Two questions. I assume we are the compliance committee sitting at this table for the wildflower court as well. And then my second question is who's on the compliance committee as the staff, Nathan, you mentioned? Who makes up that committee?
Yeah, through the chair, senior leaders are part of that, and revenue cycle team is the primary components for the hospital compliance committee.
So 1, 2, 3, 4, 5 are sitting right here?
Yes.
Okay.
Is there nobody from medical staff involved?
I would ask to the chair. I would ask, is that a common in a compliance or?
I haven't had nursing homes as part of my mix. It's not uncommon since it's treated like a department of the hospital at this point in time, but it has risks that are separate from and different, maybe different from the hospital. So, but ultimately all of that stuff should roll up to the board that's oversees each of those entities. So if there's specific risks to nursing homes, it could roll up pretty easily. I don't know enough about the legal risks there,
So
but I'm sure there's business risks.
So through the chair, I did talk to Kim Stout about this maybe before she left for holiday. So I did ask her about that to touch bases when she came back to see how the reporting, because I know we're kind of in limbo right now, but I did talk to her.
That's an area we have to straighten out. So,
yeah, through the chair, so she is a member of the hospital compliance committee. More specific to the question is, yes, this, because it's a new service line, because it has its own revenue cycle that is supposed to roll up to the hospital, that would be something that we would be very interested in looking at. At this point, you will see that some of these areas that we're identifying as new service lines, a lot of what we're looking at is how we can better understand what, in the case of Wildflower Court, they've already been operating. So right now it's a learning curve to learn what it is that their processes are, so that we can better understand where those risk areas are from a compliance perspective, billing, coding, et cetera, for the life cycle of the revenue. So yes, that is an expectation to look at that and have that roll up as well.
And of course, it'll be different from hospice, which started from scratch.
If I might, within this last year, and there's been a lot of work, and I know a lot of people have pointed to, you know, the heavy lifting of senior leadership to bring on home health hospice, the crisis stabilization, and also Wildflower Court. But what that has done, and I know we've talked about this in some of the board meetings, but I don't know that that has sunk in all the way, but we have gone from 1 license to 6. Just to kind of put that into perspective. And so, yeah, there's a lot of moving parts with them. Health facilities licenses.
Sounds like we've got a lot of work to do this year. Or whoever
Whoever's on the committee.
who's ever on the committee.
So any other comments, any other suggestions? I think, I'd be happy if we could do this for the people taking over from us, if it isn't us. Is a plan, is a suggestion.
Can I take it at a draft?
Pardon?
Can I take it at a draft, Mr. Chair?
Yes, do we want a motion to forward this on? I would appreciate that.
I think it's a manageable, over the course of a year to accomplish these.
Would you say draft? You mean to? Forward to the line.
Well, no, we can, this is just for committee for us, for you,
All right,
so.
that's fine with me. It's with committee. All right. Well.
And Mr. Chair, can I also ask, how do you like the formatting of this? This is a preview of the new bond and workflow for Erin is creating for new documents for the board for 2024. Since I know you are.
For me,
Stickler. There are no serifs.
I was just about to say,
So I was.
I would suggest, serifs for font for text, but
This
have a strong.
Is the new format of our agendas, just to let you know.
All right. Oh, I'm not gonna complain.
I would have to call Erin in.
The font is the special, all the first order headings are called orders. And that the all cap font, it's very good for bulletized. Anybody else? Suggest a different font? proposed education. So I think our last thing on our agenda is to talk about educational topics. Is there anything more to talk about here? This is what we've done. It's really a question for the next committee, but down at the very bottom of the page, proposed topics for the next year. Data security, I think that is one that we really ought to be more concerned about. Of course, the home health and hospice. We've done. Contract management evaluation, that is something that has come up in conversation in the last. Come up in conversation the last year. Of course, HIPAA is always an important topic. So I would open that list up to the committee and the staff to talk about what we might suggest for next year.
I like those topics. I took a look at them there. I think that they're appropriate for next year. In the conversation about a couple of topics ago, I mentioned high tech. I think under data security or under HIPAA, high tech is a subset of HIPAA. High tech is the health information technology. I can't remember.
Portability.
No, high tech is not HIPAA. High tech is specific to tech. It was in 2008. It was enacted that required electronic health records and has very specific compliance issues on how electronic health records are maintained, the governance of them. And this is a topic that I don't think we need to take a deep dive in, but we as a board need to be aware that it's out there and that it is a risk for us, along with our ability to keep our servers from crashing. But I think that we need in with one of those two topics, data security or HIPAA, because high tech is.
Typically, if you have a breach of information with a patient, you're violating multiple laws, one of which.
Exactly.
But you also, the type of data that gets out there is not only medical, but it can also be social security and addresses and stuff. So you typically have more than one issue that you have to deal with in terms of trying to make sure that they do it. And then, the whole issue of phishing, as well as other types of malware coming in is a real area that, we always have to be vigilant. And what I'm told is the best way to cause that is through email. It's a way in, but people can open up emails and you can also get that through. But there's a lot there around data security that would be very beneficial for us to not only be up to date on, but also make sure that we don't have those types of breaches. They're happening quite often around the United States. There was one here recently. Outside vendor.
I've looked at my Medicare statement, and it's $2,000 for catheterization, thousands of dollars for COVID tests, all stuff that I had not, that I did not have. Obviously, somebody got my Medicare number.
Yeah.
And that would be only one of 3 institutions.
The other thing, and this is probably a problem more in other areas, but it's a problem in places where you have a lot of agriculture, is that people that come in that might be not citizens will borrow social security cards and others. And so the identification of your patient, they be at risk. And so they may have information in that record that would change the physician's mind about how to treat them, unknowing that they're treating the wrong patient, and vice versa. There might be things that the patient hasn't disclosed to you that you missed because of that. So even patient identity is a big issue, and it's going to be a real big issue over the next couple of years.
Since we're famous cases down south, this is a small town, not no agriculture.
So could I suggest that we, for the purposes of discussion, that we change the data security to data security and high tech, which is something I don't really know anything about at all. When I hear high tech, I thought it's something completely different. So I'd like to at least know what it is.
I think that's very reasonable to me. Especially since we've got a new service line, I mean, we need to know about compliance regarding wildflower. Mouth. That's all new to me. I mean, I've learned a lot, just the last board meeting about some of these words that float around about reimbursement. You know, I'm not a finance guy, but that was very helpful. Thank you. From last meeting.
Okay, is there anything more to say about this?
I think I beat that horse. I think I beat that horse for this.
Any comments from staff? Are we done? Are we at the end of our agenda? Almost.
And then to the chair. So these topics I was proposing for board compliance meeting training. So, and then I was assuming that then the next year committee would look at the overall board compliance training. So once the new committee sits, whoever they or you may be, then we can come up with the plan for the next board. So the topics that I put here was for your quarterly trainings for your board compliance meetings, and then
Oh, I see.
yes,
The subcommittee, right?
yes.
Um,
And then I'm sure some of that will feed into the full board, but. So I was looking at something a little more in depth because I was looking at actually these coming off of the risk assessments. That you'll be learning about in the first quarter. So.
well, I think it'll be just very helpful. I hope it'll be helpful
Mhm.
for the next committee to have something to start with.
Yes,
And then, they may want to go a different direction and have that. be
Right.
Plans for the whole board. or not.
exactly.
But anyway, I just feel a whole lot better
Yeah.
leaving someplace to start. So is there anything more to say on that? If not, then final matter would be committee comments and questions. Is there anything that we haven't discussed that anybody in the committee or anybody would like to discuss?
I have nothing more.
Next meeting. Should we set the next meeting?
Why don't we, my suggestion would be to let the next committee find their own time.
It may be us, but it may not be all.
Because it would be in February, so you could set it. At the next board meeting. Well, you will be in Mexico
Belize, yeah.
or Belize, yes.
I suggest we set it by correspondence. And then whoever's on the committee can look at their own schedules.
So through the chair, you and I talked yesterday about maybe a verbal update, since this was
Oh,
a
yes.
second meeting in the last quarter.
Yes.
But we're done now,
No, this is a good place where, this committee comments. Maybe we can have some comments from you. We should review, did you have any calls on the, confidential line or anything in the red, any gauges in the red? That's.
Yeah, so the answer to that is no. As far as I know, Gail, you're getting.
Yes.
But just kind of high level on some of the things been working on is, we did have a state contractor, as in mentioned, had a breach of Bartlett data. So it was not us, it was not our breach, but it was our patients, and it affected about 5,000 accounts. So they're managing that process of the notifications, the public notifications, the individual notifications, the notifications to the Office of Civil Rights, and also the offering of the personal protection for identity theft and those types of things. We were also selected for Alaska Medicaid desk review. The state contracts that through Myers and Stauffer, the CPA firm. So we grab a big tranche of randomly selected Medicaid accounts and send that to them. But as part of our process on our end, after we capture those accounts, instead of just sending them on, I send them over to PFS to do our own review to see what they're going to be looking at. And when they do their own review, you know, we want to see ahead of time if we're going to get, we don't want to be blindsided. But I'm happy to report that it was reported to me that that we're actually looking really good with that group that we sent on. We're getting to the end of the year, and January 1 starts more triggers for the No Surprises Act. So we're looking at the good faith estimates, and that's something that's really interesting because we're typically the convening provider, what's known as the convening provider, which would be required to give the good faith estimates for people who come in asking for them, even if there's a co-health provider involved. So putting in communication, again, I think over the past year, we've tried to communicate out to the community providers, let them know that this is going on. We've got not a lot of feedback from them because I don't think that they feel like it involves them. So every time we send them something, it's like, yeah, that's not me. We're, you know, but there is that requirement that either they provide that good faith estimate to us so that we can hand them the document, or they're responsible for not responding. And then if that good faith estimate is challenged, then it becomes their problem, not Bartlett's. And so we're ironing out some of the communication there.
I'm not sure I understand what you're saying. So for example, suppose somebody's gonna get appendix out, so you have a surgeon on the apartment. And so you're saying that we have to give a patient a good faith estimate of the total, and anesthesia is involved. Good faith estimate of the whole kit and caboodle.
The whole bill, yes.
And if a surgeon doesn't comply, then what happens?
Then if that bill is contested, or if it's over $400 above what was estimated, then that can go to the government agency who can basically moderate and help you advocate for yourself to say, it was a bait and switch or something else.
So if you get a estimate on your appendix and then you have a coronary, when you're reduced to the anesthesia, and then a whole bunch of other stuff happens, you stay for longer. Obviously, it's going to be way over $400.
Right, but it's also going to be additional services that you didn't ask for in your estimate.
Okay. How did you get that information out to the providers? Because I, for instance, I read my email assiduously. I don't remember getting a note, and I'm a little bit aware of the No Surprise Billing Act.
Yeah, so it's come out of Patient Financial Services. They've sent it out, and we've even offered a couple different, actually 3 different times where we've had a firm come in and give education for it. Do you remember?
It's not there.
Yeah, so we've offered a lot to try to help people get involved, but
It was it was months ago.
I think it was like
Might even the end.
last year.
Yeah.
I mean, we're talking a long way up.
And I remember doing one of them actually, one online.
Yeah.
With Steve Strickler and some of the other docs, but it's something that the No Surprise Billing Act mostly affects emergency care. And so since I am not an emergency, it mostly affects anesthesia, orthopedics, general surgery, ER physicians, and in the hospital, for instance, tourists. Whereas many of the other providers perhaps were non-responsive, for instance, Valley Medical or something, because they already have agreements with Aetna and Blue Cross, and so they just, it doesn't affect them that much, so they're probably a little dragging their feet, is what I would guess.
perhaps. Yeah. Another thing that we're working on is getting ready for the APR DRG change that's coming out. This is the change for Medicaid. The way that they're billing, they're going from a per diem billing to a diagnosis related group. The state's position on this is you guys don't have to do anything because it's all done on the back end. We're gonna change the way that we organize this. And it's not gonna affect you guys a lot. I mean, it might be some variations. I think you had mentioned some of your concerns yesterday in the board meeting. But on the flip side, I don't think that the state did a very good job at looking at the front end. They're looking at the back end in the way that they reimburse, but we're anticipating that there may be some changes that we're just not aware of because they haven't told us yet all the implications of, for example, an observation patient. The way that we bill for observation and then roll into someone who actually gets admitted kind of changes. Us knowing how they're going to bill that and account for that is going to change how we do it on our front end with either documentation or even changes to our EMR. Because, you know, drop downs and again, documentation. So anyway, AHA's on board with, you know, kind of holding them to putting some screws to it for, you know, this last minute kind of thing, but it's everywhere. All of Alaska is going through this kind of thing. So there might be some last minute scrambling on that front. We talked about a new service line review of Wildflower Court, home health and hospice, and the 2 crisis licenses. We talked about the compliance risk assessment that's in final phases. And then also the physician contracting process review. So that's some of the things we've been working on. Gail, did you want to add anything to that?
No, just what I've been working on is just going through, now that we have a compliance work plan, is just I've been doing a background evaluation based on the plan and looking at an assessment of our program and going forth with that and making our KPIs and our action plan moving forward for 2024 and looking at where we have opportunities. So that's what I've been working on, and that will come forth. So.
Okay, anything else?
Yeah.
Good. And the snow?
It's raining.
No.
Oh,
It was.
I was like, I've been in this room all afternoon. It's like, darn it.
It was raining on my way.
Okay, well, thanks, everybody.
Happy holidays.
They're not, you know, with the same president and vice president, you're gonna be on this committee, running this committee again, is my suspicion.
Well, I think I'm gonna ask.
I have noticed that.